This video, presented by Dr. Vishnu Pal, Assistant Dean and Professor in the Department of Anatomy, focuses on the anatomy of the elbow joint. Let's consider a case scenario. A 42-year-old male tennis player reported severe pain over the lateral part of his right elbow. Examination revealed tenderness over the lateral epicondyle, with pain aggravated by wrist extension against resistance. The image here visually represents the condition known as tennis elbow, highlighting the area of pain. We will explore several questions related to this condition, including its name, location of pain, and underlying causes. By the end of this video, you will be able to describe the elbow joint's type, articular surfaces, ligaments, movements, muscle responsibilities, blood and nerve supply, and clinical anatomy. The elbow joint is a hinge variety of synovial joint, permitting movement in one plane. It's also a compound joint involving the humerus, radius, and ulna. Looking at the superior articular surfaces, the humerus features the lateral, rounded capitulum and the pulley-shaped trochlea, which lies medial to the capitulum. The inferior articular surfaces include the trochlear notch of the ulna, articulating with the trochlea, and the disc-shaped head of the radius, articulating with the capitulum. The capsular ligaments enclose the joint cavity. Superiorly, they attach to the medial epicondyle and the margins of the coronoid, radial, and olecranon fossae, and the lateral margin of the capitulum. Inferiorly, the capsular ligaments attach to the margins of the trochlear notch of the ulna, except laterally, where the capsule connects to the annular ligament of the superior radial-ulnar joint. The synovial membrane lines the inner surface of the capsule and extends deep to the annular ligament, making the elbow joint's synovial cavity continuous with that of the superior radial-ulnar joint. Additional ligaments of the elbow joint include the ulnar collateral ligament and the radial collateral ligament. The ulnar collateral ligament, also known as the medial collateral ligament, is triangular. Its apex attaches to the medial epicondyle of the humerus, and its base to the coronoid and olecranon processes of the ulna. The radial collateral ligament, also called the lateral collateral ligament, is fan-shaped. It attaches superiorly to the lateral epicondyle and inferiorly to the annular ligament. The blood supply around the elbow joint forms an anastomosis, involving the brachial artery, radial artery, and ulnar artery. This diagram illustrates the complex arterial network around the elbow, highlighting branches like the posterior descending branch, radial recurrent artery, superior and inferior ulnar collateral, and ulnar recurrent arteries. This detailed diagram further clarifies the intricate vascular connections, showing the brachial artery, collateral arteries, and recurrent arteries contributing to the elbow's blood supply. The elbow joint is innervated by the musculocutaneous, median, ulnar, and radial nerves. Anteriorly, the elbow relates to the median nerve, brachial artery, biceps tendon, and brachialis muscle. Posteriorly, it relates to the triceps brachii tendon and anconeus muscle. Medially, the ulnar nerve, common flexor origin, and flexor carpi ulnaris are found. Laterally, relations include the common extensor origin, supinator, extensor carpi radialis brevis, and muscles from the radial collateral ligament. As a hinge joint, the elbow permits flexion and extension with a range of approximately 150 degrees. Key muscles for flexion are the brachialis, biceps brachii, and brachioradialis, while extension is handled by the triceps brachii and anconeus. This slide displays anteroposterior and lateral radiographs of the right elbow joint, offering a visual perspective of its bony structures. The carrying angle is the angle formed by the arm and forearm when the elbow is extended, typically around 13 degrees. This angle disappears in full flexion and during forearm pronation. The carrying angle differs between sexes, 10 to 15 degrees in males and over 15 degrees in females. This diagram illustrates the concept of the carrying angle in an extended elbow. This image highlights the bursae associated with the elbow joint from a lateral view. In clinical anatomy, common elbow conditions include posterior dislocation, often with a coronoid process fracture, subluxation of the radial head in children, tennis elbow, student's elbow, golfer's elbow, and elbow aspiration. Elbow dislocation is typically posterior due to the capsule's thickness, strong collateral ligaments, and the olecranon process's hook-like shape. It may involve a coronoid process fracture. Subluxation of the head of the radius, known as pulled elbow, is a common occurrence in children. Student's elbow, or olecranon bursitis, is an inflammation of the subcutaneous olecranon bursa. It often results from repeated minor injuries from resting the elbow on hard surfaces. This image provides a visual representation of student's elbow, showing the swelling characteristic of olecranon bursitis. This visual further depicts the appearance of student's elbow, emphasizing the affected area. Tennis elbow, or lateral epicondylitis, causes pain and tenderness over the lateral epicondyle, exaggerated by movement. It's often due to abrupt, repetitive forearm pronation, common in tennis players. This image visually represents tennis elbow, highlighting the area of pain on the lateral epicondyle. Golfer's elbow, or medial epicondylitis, involves pain and tenderness over the medial epicondyle. It results from trauma to the common flexor origin, common in golfers, due to repetitive use of forearm flexor muscles. This image illustrates golfer's elbow, indicating the typical site of pain on the medial epicondyle. Elbow effusion is the distension of the joint cavity due to inflammatory fluid accumulation. This commonly occurs posteriorly due to the capsule's weakness in that area. For elbow effusion, fluid aspiration should be performed from the lateral side of the elbow. A needle is passed into the triangle formed by the olecranon process, lateral epicondyle, and head of radius. This diagram provides a visual guide for the aspiration of fluid from the elbow joint, illustrating the correct needle placement. Thank you for watching this video on the anatomy of the elbow joint. Let's revisit our case scenario about the 42-year-old male tennis player with severe elbow pain. Addressing the questions raised earlier, this condition is called lateral epicondylitis, also known as tennis elbow. The pain is located over the lateral epicondyle of the humerus. This condition is caused by repeated forceful extension of the wrist and abrupt pronation of the forearm, often seen in sports like tennis, swimming, basketball, or table tennis.